Dermatophytosis is defined as superficial fungal infection caused by dermatophytes. It affects keratin bearing structures, that is, the skin, nails, and hair. It includes Tinea corporis or cruris, Tinea pedis or manum, onychomycosis, etc. In this case, we advise all patients to take treatment regularly as advised and never stop without consultation after obtaining some relief to prevent relapse. We should also advise patients to not self medicate because it can make the infection difficult to treat. Patients should not ever use any steroid containing OTC cream. Tinea corporis or cruris. On examination, we find itchy, scaly lesions on the skin, typically annular, that is, ring like lesions with variable scaling or flaking, and erythema. Always examine groins, buttocks, nails, palms, and soles. Ask for lesions in other family members. For diagnosis, in doubtful cases, KOH microscopy of scales shows the typical septate hyphae. Culture and other advanced methods are not required in routine practice. General measures advise the following do's and don'ts to the patient. Do's: take daily bath with regular bathing soap and normal temperature tap water. Dry skin well after bath. Wash clothes separately in hot water and dry inside out in the sun. Don'ts: do not share towels and clothes. Do not rewear clothes before washing. Treatment includes topical antifungal for limited involvement in case of Tinea corporis and cruris. We can use clotrimazole 1% or 2% cream BD, miconazole 2% cream BD, terbinafine 1% cream BD, ketoconazole 2% cream BD. For extensive disease, it is not feasible to use antifungal creams alone. So advise oral antifungals or advise antifungal creams over most bothersome lesions only in addition to systemic drugs. Treatment in children: always look for infection in the parents or caregivers. Prefer topical antifungals for younger children. Oral antifungals should be given on weight based dosing. Terbinafine 3 to 6 milligram per kilogram per day can be used, or for less than 20 kg 62.5 milligram, 20 to 40 kg 125 milligram, more than 40 kg 250 milligram can be used. Fluconazole dosage is 6 milligram per kilogram per day. Risuofulvin dosage is 10 to 20 milligram kilogram per day. Refer the case to a specialist or tertiary center if there is very extensive disease, there is no or minimal improvement with regular treatment after 4 weeks, cure is not achieved despite prolonged treatment and good compliance, recurrent infection, and there are comorbid conditions present like pregnancy, lactation, hepatic disease, renal disease, or cardiac disease. If there is history of prolonged topical, oral, or parenteral or steroid use, remember the lesions are often modified by self-application of topical steroids or combination product. Appear as the ring to be incomplete, scaling may be minimal, pigmentation may be prominent, and do not use any steroid containing cream. Ensure treatment for adequate duration to prevent relapse. Tinea pedis or manum. On examination, we find a dermatophytic infection of palm, that is Tinea manum, and soles called Tinea pedis. Generally, unilateral involvement is present over the toes, webs. Scaling may also be present along the creases of palms or soles only, or it may be diffuse. Occasionally, dried vesicles can be seen. A scaly margin with or without erythema may be seen at the level of the wrist for Tinea manum and at insteps or outsteps of feet for Tinea pedis. Coexistent involvement of nails is also common. General measures: prolonged treatment is required. Treatment with adequate dosage for recommended duration should be adhered to. Advise patient to avoid walking barefoot in public places, especially swimming pools or community bathing areas. Wash feet with bathing soap and normal temperature tap water. Wipe and dry well with a towel. Dry toe clefts before wearing shoes or socks. Wear cotton socks. Wash worn socks separately in hot water. Treatment: systemic treatment. Always treat till lesions are completely resolved. This may take between 3 to 8 weeks or more depending on the extent of infection and previous treatments. It may take longer when palms or soles are also involved or there is history of prolonged steroid use. Follow up regularly every 2 weeks. Oral antifungals that are given for adults include terbinafine 250 mg BD or tab griseofulvin 500 BD, tab fluconazole 50 to 150 mg OD. For relief of pruritus, tab cetirizine 10 mg HS or tab CPM 4 mg TDS can be. Treatment in pregnancy, preferably use only topical antifungals. Maximum safety data is for use of miconazole cream or clotrimazole cream. Limited safety data in humans to recommend use of any systemic antifungal during pregnancy, especially first trimester. If required, fluconazole may be preferred. Management at tertiary care. Treatment should be individualized. Treat till complete clinical and mycological cure, that is, KOH negativity is attained. Then for culture, speciation, and antifungal susceptibility testing if available. Topical treatment over limited areas only. In addition to previously mentioned regimens, luliconazole cream topically once daily or cetoconazole cream topically BD can be given. Systemic treatment includes cap itraconazole 100 to 200 mg per day or tab terbinafine 250 mg BD. Ensure treatment for adequate duration to prevent relapse. Onychomycosis. It presents as discoloration of nail with buildup of keratinous debris under the nail plate. It generally affects isolated nails asymmetrically. The whole nail may crumble in advanced cases. Look for simultaneous involvement of palms or soles. Ask for diabetes and signs of peripheral vascular disease. Gentle measures. Advise patients to keep affected nails trimmed as they are fragile and trauma prone. Keep separate nail clippers. Avoid any cosmetic nail procedures, pedicure or manicure. Inform the patient that it might take several months after treatment completion for a completely normal looking nail to appear, and in severe cases, a cosmetically acceptable result may not be achieved. It is important to treat the nail infection as it is a potential focus for spread of the fungus to other body sites. Treatments can be with topicals if the disease is limited with less than 50% nail sulfurs involvement or not going back till the lunula, or patients with contraindications for oral antifungals, that is renal disease, etc. We can use amorolfin 5% nail lacquer application once a week or cyclopyrox 8% nail lacquer thrice a week. Systemic antifungals used include tab terbinafine 250 mg BD, given 6 weeks for fingernails and 12 weeks for toenails, or cap itraconazole 100 mg BD for 12 weeks, or 200 mg BD per day for 7 days a month, 2 such pulses for fingernails and 3 for toenails. Here also ensure treatment for adequate duration to prevent relapse.